Hello and welcome, everyone. I am Autumn Lintz, the Education Manager here at the Foundation. I wanted to thank you for joining us today for our answers from the experts. We're very excited to have you, and we are about ready to get started. Before we do, I would like to go over some housekeeping, questions and answers. That is why we're here. I know some of you did submit some questions during registration, but please add your questions to the Q&A tool as we go. We have had an unbelievable response. We have lots of questions, and we are going to do our best to answer them all. We will be sending a recording of this webinar after it happens, and you can watch it on our YouTube channel in a few days. We'll also send that via link to everyone who registered. We would also like to thank our individual donors and our funding partners for making programs like this possible. We cannot do it without your donations and our funders. This is how we exist. This is how we are able to produce patient education forums, webinars, publications, and other education materials. So thank you for your donation. Upon the conclusion of this webinar, there will be a survey that pops up on your screen as you exit. We really would appreciate you taking the time to complete the survey. We do use this feedback to guide future programs and to ensure that we are meeting the needs of our community. So please take the time to complete this. If you are not already on our mailing list, please join our website and you can get any additional education information, join our community connections for peer-to-peer opportunities, and as always, follow us on social media to stay updated. Now, I would like to introduce our speakers to you. First, we have Dr. Guitart, who is the Chief of Dermatopathology in the Department of Dermatology. He is a professor of dermatology and pathology at Northwestern University Feinberg Medical School. He is currently on the editorial board member, International Dermatopathology and Journal of Cutaneous Pathology. He has numerous peer-reviewed publications, and his research is centered on diagnosis and treatment of various subtypes of cutaneous lymphoma. He also has participated in several clinical trials over the past 3 decades. We also have Dr. Geskin joining us today. She is professor of dermatology and medicine at Columbia University Irving Medical Center, and she's also the director of Comprehensive Cutaneous Oncology Center at the Department of Dermatology. She is a diplomat of the American Academy of Dermatology and immediate past president of the International Society for Cutaneous Lymphoma. She also has authored over 150 peer-reviewed articles, book chapters, and books in the field of cutaneous oncology. Her research interests focus on cutaneous T-cell lymphoma and biomarker discovery, genetic profiling and regulation, development of immunotherapy for melanoma and lymphoma. So let's go ahead and get started. Welcome, Dr. Geskin.
Thank you.
And welcome, Dr. Guitart. Okay, we're going to go ahead and start with our first question now. For LYP, is there a reason why systemic treatment medication is preferred over localized topical treatment?
We have therapies for lymphomatoid papulosis. We do not have a cure for lymphomatoid papulosis. Oral methotrexate in a very low dose, which is very safe and has very few side effects, is, in my opinion, what works the best. A dose as low as 5 to 10 milligrams per week can control, if not entirely, can really limit the number of lesions. So methotrexate works very well for the people who do not like to take oral medication. Narrowband UVB also works well, but is, in my opinion, not as effective as low-dose methotrexate.
Thank you so much.
I just would like to add, if I may, that I completely agree with Dr. Guitart. You know, one of the reasons we need to use systemic medication for lymphomatoid papulosis is because you never know where your next spot is going to appear. But some patients may have just a couple of spots. Lymphomatoid papulosis is a very diverse group of conditions in which some patients develop just 1 or 2 spots over months, and some people have hundreds of spots. And so the more spots you have, the more you benefit from systemic therapy. But if you have just a couple of spots, sometimes we do use topical steroids, potent topical steroids. Start having an itchy spot, you know, the spot of LYP is coming, and you can start applying the steroid even before it erupts, and it may stop it in its tracks. So it may be quite beneficial sometimes just to use topical steroids, but it's only in cases if you have very clear and or if they are not bothering you. But if people have many spots, you know, certainly there is no better treatment than methotrexate. Light in that.
Okay, thank you both for that answer, and I apologize again for our little audio glitch. Our next question is, how effective is surgery to remove lesions of PCALC? How deep should they go? Does it remove muscle or lymph nodes?
Larisa, I defer to you, or you want me to go?
Yes, sure. We can respond to this. You know, surgery is one of the ways how primary cutaneous anaplastic large cell lymphoma can be treated. It's usually a localized disease, and it's usually comes in a single spot, but always. When it's just a single tumor, sometimes we just excise it. We don't really have to go to the muscle. We don't really have to remove the lymph node. In fact, we don't even have to do surgery because sometimes radiation therapy works just well, and it may be meant to irradiate the tumor, and it just melts it away, and that's that. But yes, sometimes some patients prefer surgery because it's a single procedure, and it may be quite effective. It may remove it completely, but because it's a lymphoma, it's not a specific kind of like a skin cancer. It's a malignancy of white blood cells. There is really not a right margin that takes. So sometimes we see recurrences after surgeries, even though I have to say I did surgeries for several of my patients and the lymphoma stayed away. But this is not always the case based on the literature that we know of.
Yeah, in my experience, if I may add something, I mean, I read the pathology and you don't have to go beyond the subcutaneous tissue. So the fatty tissue under the skin is usually enough. Very seldom this type of lymphomas go into the muscle or bone is very exceptional. And as Dr. Geskin was mentioning, checking margins is not that important because this type of all lymphomas, the lymphocytes, they tend to circulate. And if you are going to have a recurrence of the disease, if you're going to have like metastatic disease, it may happen anyway, whether you have a complete excision or you have a partial excision.
Okay, that was great. With patients being treated with mogamulizumab, how long have you seen consistent efficacy?
I have seen a few patients with control of the disease for a few years. I don't have a very extensive experience with mogamulizumab. We use it mostly for patients with Sezary syndrome. I've been very impressed with long-lasting efficacy in some patients, but not on the. It's more common to see a recurrence of the disease after a few months than a long-lived remission, in my opinion.
Right. Yes, in a pivotal clinical studies, the response to mogamulizumab lasted for a couple of months, but this is over hundreds and hundreds of patients. And so some patients had a very short lasting response, but many patients had a long-term responses, and my experience is very similar to Dr. Guitart's, that some patients benefit long-term. Of course, unfortunately, we cannot tell who is who and for how long each patient is going to benefit from a particular drug, and only kind of trial and error type of situation will show us how well some patients may respond to certain drugs.
All right. I think this next one, Dr. Geskin, might be more geared towards you. When is the best time to start treating MF patients systemically?
So this is a very, very individual question. It really cannot be answered as a kind of blanket. I cannot really give you a blanket answer because, of course, most of the advanced, what we call advanced stage patients, patients with stage 2B and more advanced, they usually require treatment with systemic therapies. But even in those patients, sometimes we use phototherapy, for example, in patients in radiation therapy with patients with tumors, and they may have lasting responses without even the need for systemic therapy. So the need for systemic therapy is determined by the disease course and by the way the patients feel. As we all know, as Dr. Guitart just mentioned, same as with lymphomatoid papulosis, cutaneous T-cell lymphoma, short of very, very exceptional cases, is a chronic illness that requires long-term therapy. And so we are trying not to be very aggressive and not to damage the immune system that actually something that we would like to preserve a intact function of the immune system so the patient fight off other infections and cancers and stay as healthy as possible. And so certain systemic therapies may be immunosuppressive or may not be suitable for long-term use, but we have many good ones that are suitable for maintenance therapy, such as bixarotene, for example, or interferon, and some other ones that are not immunosuppressive. For photopheresis, for example, it also not immunosuppressive therapy, among several others.
Okay, thank you.
I think this is a type of question that if you ask a dermatologist or an oncologist, you'll get a different answer. My approach, after like 30 years of treating patients with CTCL, is that I like to stay on skin-directed therapies for as long as possible. Over time, if with the skin-directed therapies we cannot control the disease, or if there is more signs of progression, then I like to combine the skin-directed therapies like phototherapy with retinoids like bixarotene or interferon. And we really try to limit the use of systemic chemotherapies until there is advanced disease, there is like nodal involvement or large tumor lesions that don't respond to radiation. Because we know that chemotherapy tends to only give us like short responses. So as long as you can go, as Dr. Geskin was mentioning, preserving the immune system, just attacking directly the skin with radiation, with phototherapy, with topical steroids, the better you're going to be than switching to chemotherapy, which, as I was saying, the results, they don't tend to be very long lasting.
All right, thank you both so much. So this next question, I think, is something that we just may have to direct them to talk to their own physician, but it's regarding her husband has Sezary syndrome, and they're thinking that the booster for COVID-19 may have made his symptoms worse.
I think it's quite an interesting question because actually, Dr. Guitart, I'm sure you can share your case where patients' Sezary syndrome actually went away or went into remission. And so I think there are cases that are helped by the vaccine or helped by the boosters. And there are cases that are made not necessarily worse, but I think because the immune system has been engaged, the disease may be going through the flare, but my patients who had flare after vaccine, they all recovered and went back to their pre-vaccine conditions. But I would like to hear Dr. Guitart's take on it because they had very interesting experience with that.
Yeah, we know that those mRNA vaccines, they activate your immune system. As a matter of fact, we've seen a number of cases coming to our clinic with what we call like pseudo lymphomas or low-grade lymphoid lesions in the skin that turn out to really not cause a major problem. A curious case is a patient we had like about a year ago with Sezary syndrome who achieved a complete remission. I mean, the patient had a few thousand Sezary cells in the blood, and upon completing the course of COVID vaccination, the tumor cells were gone. So the patient did well for a long time, and eventually there was recurrence of the disease. But so the response is pretty much unpredictable. But we have seen cases that is exactly the opposite: improvement of Sezary rather than worsening.
Okay, thank you for that information. Should MOGA and ECP be used simultaneously? Dr. Guitart, would you like to take a stab at this one?
Should MOGA and ECP? I believe there is a study, there is a proposal of a study for this combination. We don't really know much about what happens with extracorporeal photopheresis, but what we do know is that, in a way, it's almost like a vaccine effect. With extracorporeal photopheresis, we pretty much cause cell death of the cancer cells in the blood, which release antigen, and it activates what we call the antigen-presenting cells to invigorate the immune system. So, to some extent, MOGA may be helping that mechanism by not only attacking the cancer cells, which will free dead cells to become like an antigen against, so like a vaccine type of effect, but it also depletes what's called the T regulatory cells, which is a subtype of lymphocyte that tames down the immune system, which is exactly what we are trying to avoid during the treatment of mycosis fungoides. During the treatment of mycosis fungoides, we like to activate the own immune system to attack the cancer cells. And by combining MOGA and extracorporeal photopheresis, this, at least theoretically, this is a viable combination therapy.
All right, Mike, can we have the next question, please? Can PCALCL move into the lymph nodes? And if so, is it common for the disease to spread quickly throughout the entire lymphatic system? Dr. Geskin, is this one more for you?
I think it's for both of us, but I certainly can take it. The primary cutaneous anaplastic large cell lymphoma, by and large, is more of a localized disease for many patients. It's unusual for primary cutaneous lymphoma, anaplastic large cell lymphoma, to move to the lymph nodes. And in fact, when something like that happens, I'm wondering if it wasn't systemic lymphoma to begin with. In some of these cases, though, it may extend to the lymph node and cause a real nodal disease, but usually the PCALC has a favorable prognosis, and vast majority of patients with this condition do quite well. But I'm curious to hear what Dr. Guitart, what your experience with the PCALC.
Yeah, so primary cutaneous anaplastic large cell lymphoma is a rare lymphoma that's in the spectrum of lymphomatoid papulosis. So when lymphomatoid papulosis becomes like a large tumor lesion, we call it anaplastic large cell lymphoma. Now, anaplastic large cell lymphoma can go to the lymph nodes, but that's extremely rare. Maybe less than 10%, maybe 5% of the patients with primary cutaneous anaplastic large cell lymphoma will have nodal involvement. The nodal involvement can be a single node that is treatable with radiation or excision, or you can have extensive involvement. In my experience, patients with anaplastic large cell lymphoma, less than 5% require systemic therapies with like something like brentuximab due to internal organ. It does happen, but it's exceedingly rare.
All right, thank you for both of those answers. So our next question is about any clinical trials for Sezary syndrome near Ohio. And for the person asking this question, on the cutaneous lymphoma website, we do list the treatment centers and any current clinical trials. So if either of the doctors aren't aware of any in Ohio, you can find that information on our website. Okay, Mike, the next two questions are long questions that came in live. So I wanted to leave the questions up during the answering because they are a little bit more in-depth and multi-part. So our first one is regarding MF and Sezary. What is the best resource for detailed statistical reports on demographics, treatments, and outcomes? For example, MOGA. What are the latest theories about mechanisms for these diseases, including cartoons of T cells, where they come from and where they go and how they can go wrong? That is a lot of an ask right there, but I wanted to see if either of you could touch on any aspects for this.
You know, I think it's a really great idea to write such a review for the patients, because I am actually not aware of a single resource that would have cartoons and would have explanations and details like that. There are numerous publications, including recent publications in Nature reviews on CTCL going over all of this, but it's all written for the doctors. But I don't know, Joan, do you know of any resource for the patient that would have kind of detailed mechanisms and such that is in a kind of in a cartoon form?
I'm not aware of such a source, but I know that the Kyowa Kirin is a sponsor of the Cutaneous Lymphoma Foundation, and they are very eager to inform the patients, and I'm sure they will have the resources to provide some similar type of tool for our patients. So I think it's a great idea, and we should ask Kyowa Kirin for some assistance there.
Yeah, and also in something like that, they also can, you know, voice their desire to have this type of publication, and so maybe search for funding for this type of work.
Yeah,
I can also.
What we know about the mogamulizumab is that is an antibody that attacks the cancer cells. The cancer cells express this molecule CCR4, which will cause the complement, the immune system, to attack the cancer cells, and at the same time, as I was mentioning earlier, remove those T regulatory cells that are they do not help, they tame down the immune system. So we know that it has a double effect, directly attacking the cancer cells and removing the cells that slow down your own immune system. So that's a cartoon of what happens. But it would be nice to have something done more professional.
So what I will do is I will reach out, as Dr. Guitart said, to Kira Keown and see what they have. We also had someone put in the chat to contact the team at the Hive at UBC that they work on these types of visualizations. So that was something one of the attendees shared with us. Okay, so our next one probably is a little bit too big for our chat bubble, so I'm going to kind of go through it. They're talking about their mother who has Sezary syndrome, stage IVA2. The treatment had been methotrexate back in February, March, supposed to start ECP, but has now been hospitalized, is on a port and antibiotics, and their current doctor wants to wait to start the treatment. And the concern is weight on the weight of it. So the question is, do you have any suggestions on other treatments that she can start? She is on Zoysin, Z-O-S-Y-N, if I'm not pronouncing that right, for antibiotic treatment. Should she be getting another opinion? I do not believe her oncologists have worked with Sezary patients before.
It's hard to provide advice on a case that we don't know anything whatsoever. We know stage 4A2 is advanced. It's advanced disease. Usually the extracorporeal photopheresis by itself is not sufficient to control such an advanced stage. There are definitely, like mogamulizumab is one of the options. There are lots of systemic, but this sounds like a case that would be ideal for systemic chemotherapies. I mean, right now this patient sounds like there is an infectious going on. Obviously, that's a priority. Once the patient is stable, once the this infectious process is under control, you can start considering therapies. But I mean, it's hard to opine on a case that we don't know much in terms of details.
Yes, I just want to reiterate that we do not provide on question and answer sessions like that. We do not provide specific clinical recommendations just because I want to think good doctors, and we need to know many details about each individual patient to pick the right therapy for them. And while we're happy to provide second opinion, we do need to have formal evaluation of the patient, and we're happy to help otherwise. But we cannot do this on the forums like that, unfortunately.
Yes, and thank you very much for making that point. So our next question is, what is the consensus on maintenance NB UVB for early stages, or only treat of lesions when lesions appear?
I mean, there is no consensus on maintenance narrowband UVB. As a matter of fact, there's a lot of controversy. Some people, I mean, I think we all agree that once UVB works very well for patients with patch or plaque stage disease, mycosis fungoides, number one. Now, once you get a good result, I think everybody pretty much agrees that you need to consolidate the good results by prolonging the therapy at least another 3 to 6 months. Now, when to stop the treatment is controversial. In my practice, I like to decrease the frequency of treatments. And usually I stop in Chicago, which obviously we have a long winter here. I stop the treatment of UVB in the summer months once the patients have achieved a good response. But there is no consensus. I believe that decreasing the frequency of UVB treatments, maintaining the good response is an indication that the patient is doing very well. I do like to slowly decrease the frequency, but again, not everybody is of the same school. So I'll be curious to know if Dr. Geskin provides maintenance treatment or not on patients on phototherapy.
Yes, so I completely agree, There's no consensus. And in fact, there are several schools of thoughts on the subject of maintenance therapy with narrowband UVB. One of them are very strict proponents of maintenance, and the other is opponents. And so depending on who you talk to, you can get two different answers. But the truth is, as Dr. Guitart said, there is really no data, and we like to base our treatment recommendations based on data. One thing I have to say that, during COVID pandemic, we had discontinued narrowband UVB therapy for several patients who were coming to the office. And these people, some of them got the home units, but several of them could not come and stop therapy, and they did have relapses. And so this is something that we are publishing now. This is an International Society of Cutaneous Lymphomas publishing a manuscript which describes the experience of interruptions of treatments for patients with cutaneous lymphoma, whether they were on narrowband UVB or anything else. And it looks like maintenance therapy is important. At least it seems from that observation that we made during pandemic that interruption of therapy was leading to disease relapse. And so for whatever it's worth, this is something that is in support of school of thought that some maintenance therapy is necessary, but we still don't know for how long it is necessary. And certainly in the summer months when patients can get a just natural light, free light, it's always a good idea to do that.
Okay, thank you both. So we've just had a slew of questions added to the chat and the Q&A, so we're going to try and get through as many as we can, but still provide as best answers that we can. So this next one is, can you talk about some new CAR T treatment specifically for T-cell lymphomas, formerly was targeted to B-cell?
So this is a highly investigational therapy in T-cell lymphomas. unfortunately, as many of you may know, each of us and each of patients with cutaneous lymphoma is very individual, and B-cell lymphomas are very different. They are all alike, or many of them are alike, and so it was possible to make a CAR T, those toxic T cells that would recognize cancer and attack a cancer based on that particular receptor that present in all similar B-cell lymphomas. This is not possible for T-cell lymphomas. T-cell lymphomas are a completely different animal altogether. And so now there are pieces of a T-cell receptor that are studied for CAR Ts, and there are clinical trials that in advanced stages. So we are hoping to get CAR T therapy for CTCL at some point, but it's not there yet.
Okay, and our next question, my husband only uses light treatment, but we are interested in more advanced treatments. What can you recommend in addition to this? And again, with the caveat, without knowing the history and seeing the files, we have 3 or 4 questions in a row that are similar on these, and someone actually took your statement to heart and was asking for a hunch and opinion. So I think we're understanding that this is just based purely on the questions and not very specific to that patient.
I want to say that many patients do very well just with light therapy. So if you are doing well with UVB, you don't need anything else. Now, I suspect that the person who's asking this question is telling us because the light therapy by itself is not sufficient. So patients who achieve a partial response with UVB and they still are having problems, we can always do a combination therapy. My favorite ones are, number one, adding retinoids, what's called acitretin or bexarotene, low dose, or combining it with interferon, as well as obviously topical corticosteroids, which are always welcome in the treatment of patients with early disease mycosis fungoides. But I'm a strong believer of combining retinoids and interferon with the phototherapy when UVB by itself is insufficient. As a matter of fact, adding certain retinoids like acitretin may have a special advantage because it provides what we call like a photoprotection. It can slow down the formation of skin cancer. So it's a good idea to add retinoids when UVB by itself is insufficient to control the disease.
I'm also wondering, sometimes people, who are on topical therapy, so just any therapies, they tell me that they want aggressive therapy. And I just want to remind my patients that the condition that they have is chronic condition, short of stem cell transplantation, which is also a very severe, very significant therapy that actually may result in very poor outcomes sometimes. It's not an easy therapy for everyone. This is the only possible cure that we have. Everything else is just for symptom control, for quality of life, for making people feel better. But it's not something that is a curative. And for that reason, whether you go less or more aggressive does not necessarily is going to change the course of the disease. And in fact, the less aggressive therapies may preserve your immune system so it's more healthy, it's intact to fight other infections or other cancers. And so in fact, a long time ago, 30 plus years ago, the study was done comparing very aggressive chemotherapy to just topical therapy, and the outcomes were actually better in less aggressive therapies. So aggressive therapy is not always the answer. It's sometimes the answer, and some patients do need to be treated aggressively. But aggressive therapy is not the goal. aggressive therapy is just the means to get to where you need to get. It's really not something that you need to strive for.
Thank you very much. That was very helpful. So we're down to a little under 15 minutes, and we still have a significant amount of questions to go. So we're going to move into what we call the lightning round and try and get through as many of these as we can. So this is one that they took it to heart and said, in your opinions, do you have a hunch as to whose degree disease will progress? If so, what are the tells?
I think Dr. Guitart wrote several excellent manuscripts and studied this subject. So maybe Dr. Guitart, you would like to take this question?
It's a tough question, but one thing that we look for is whether there is any evidence of acceleration of the disease. Patients who had a stable disease, like let's say a few patches that year after year are not expanding, they are not turning into plaques, they are not turning into tumors. So the lack of acceleration within a few years, so past performance is the best predictor of future performance. If we see that the case does not have momentum, does not have acceleration, that's a very good sign. To the opposite side of the spectrum is patients who present with a few plaques, a few months later they come back, they start developing tumor lesions. Those are the ones that we are going to have a more aggressive disease course, because they are the ones more likely to progress and require like chemotherapies. So going back to what we were mentioning earlier, every patient is a completely different situation. Some patients with very limited patch stage disease, they do so well that you can tell the patient this is not going to be a problem for the rest of your life, especially if we've seen them stable for many, many years. But in my opinion, what really is the best predictor of outcome is the presence or absence of disease acceleration.
Okay, thank you very much. So this is more of a shout out to Dr. Geskin. I've been in remission on MOGA for 1.5 years, symptom free. Dr. Geskin, I saw you in 2018 and I'm now treated MSK. You were so inspirational. I hope our paths cross again. So I just thought that was a nice one that was put in the chat to share. As treatment goes along, do you ever re-biopsy? If not, is it because it is cost prohibited, or is it assumed that biopsy will always show cancer to some degree?
Biopsy sometimes because we are looking for new therapies. So we know that the disease evolves over time. We know that if the patient is developing new new lesions which are resistant to the present therapy, we want to know why. In some cases, we find that the morphology of the cells is changing, what we call like large cell transformation. We may find out that the cells are growing at a much faster pace. That's important for the clinician to know. Also, one other important aspect of rebiopsying is to study if there is any molecules at the surface of the tumor cell which may be a target for us. We know that we have targeted therapies against several molecules now, and the absence or presence of those molecules in the tumor is going to provide some guidance to the doctor about what's the best way to treat the patient. So do we biopsy the patients? Absolutely. Another issue is that sometimes a lesion that may appear to be disease progression may turn out to be something completely different. So before we jump into a new treatment option that can cause harm to the patient, we like to make sure we are dealing with the same disease and not something that may require a completely different therapy.
Dr. Geskin, would you like to add anything?
Yeah, I think Dr. Guitart is absolutely on target with that one, and I just have to agree with what was said.
Okay, thank you. Our next question on MOGA: since November of 2018, blood and Sezary are good, skin is not. Do you have any advice?
This is kind of typical response to mogamulizumab. It's really very effective in clearing blood. It may not be as effective in clearing the skin and lymph nodes, and so frequently we do combine mogamulizumab with the skin-directed therapies, including things like electron beam radiation. And so for patients who have extensive disease on the skin, sometimes adding light therapy, sometimes adding radiation therapy, or sometimes adding other systemic therapies may work really, really well. But again, this is not something we can possibly tell from the question like this. This is just a kind of a framework that I'm mentioning.
But this would be a good example of when to take a new biopsy, because we know that often patients with MOGA, they have like redness of the skin arise that can resemble recurrence of the disease, and is nothing but a reaction to the chemotherapy. So before we endorse any new skin-directed therapies, which I totally agree with Dr. Geskin, that's the way to go. It would be a good idea to take a sample and prove that the quote-unquote skin disease is truly the lymphoma and not something else.
Good, thank you. Have you ever considered fenretinide as a primary therapy for CTCL?
So fenretinide is an investigational agent. It actually was, it's similar. It's in the same family of drugs as bixarotene, as acitretin. It's a derivative of vitamin A, which are very effective in patients with cutaneous lymphomas. However, this particular drug is not available on the market yet. It's in the clinical trials. It's been investigated in lung cancer. It was shown to be effective in certain eye diseases called macular degeneration, but it's in the clinical trials for lymphoma. So I am looking forward to FDA approval of this drug. So we will see if it works for CTCL, but we don't have that knowledge yet.
All right, thank you. If a patient has an atypical presentation, in what cases is this a call for alarm in terms of presentation? It's a little bit of a broad question, so I'm not sure if there's really a broad answer that can be given.
Devil is on the detail. I don't know what an atypical presentation means. An atypical presentation of what? So I don't think we can apply on something that we don't know what's the situation.
So if whoever's on the call can clarify that question, we can try and slip it in, because we're actually about to run out of time. So we just have a couple of more questions that we can do. I heard it is not suggested to cut out nodules, papules, bumps in the skin. I would like to know why this is the case.
Well, this is kind of going back to my response on anaplastic large cell lymphoma of the skin. This is a condition of white blood cells. They are circulating cells. And so the moment you cut out one bump, you may develop another right next to it, and you cannot keep cutting. It's not the same as would cut out let's say a mole or remove a seborrheic keratosis, a benign skin overgrowth that is on the skin. This is a systemic disease usually, but the one that we can treat with either topical therapies, skin-directed therapies, or systemic therapies. And for that reason, usually if you have several spots, the surgery is very rarely is the answer, if ever.
Okay, thank you. So this is going to be, unfortunately, our last question because we are about out of time. And again, this is one where it's going to be more in generals, is can you talk about lifespan? My husband has a Sezary syndrome. Everything online, there's the scary, I looked it up online, says 2 to 4 years, but this doctor says decades.
I think, you know, one of the things that you will never see is survival, how long patients live. So all the survival data is coming from retrospective studies, and the reason is actually pretty good for that, because patients live long lives. And my previous mentor who actually trained me, he was saying that we never have survival as an endpoint because patients live longer than doctors. And certainly it is true for some patients and some doctors. But I have to say the survival that is published from the old studies, I don't think it's the same now. I think we're very lucky to live where we live now and not before, because before really there were no therapies that would prolong life. And even though we do not have overall survival or disease-specific survival as an endpoint necessarily in our clinical trials, we do observe that our patients do much better than their historic controls, the controls that were published by those publications that when you go on Google and see those 2 to 4 years. So if you look at more recent publications, you will see that patients live 5-10 years longer than predicted.
I agree with you, Larisa. I always thought that that's because I'm a great doctor, but it's not true. The issue is that we have all those great new treatment options now that they did not have 10, 15, 20 years ago. So truly now we are being able to achieve pretty amazing results in our patients, which is very gratifying, I have to say.
And I think it's also, sorry.
No, but it's
also because I'm a doctor too, I want to add. I know Dr. Guitart for many, many years. And so I have to say in good hands, patients do quite well.
That's true.
Thank you both so much. That's going to be our last question, but I wanted to see if either of you had any additional thoughts that you'd like to add before we wrap up.
I just wanted to add, I was thinking about the question about the atypical presentation. That was a little confusing, but you know, actually, many patients with mycosis fungoides go through years of uncertainty in the diagnosis. And sometimes the patients express like frustration. They are upset, you know, why are the doctors not able to provide me a diagnosis? They call this atypical, but they are not sure. And I just want to say that that's exactly the nature of the type of lymphoma. You know, for us dermatologists, we have direct access to the skin. So we can see the early stages of the lymphoma, which is something that doctors that treat with the liver or the lymph nodes, they don't see anything until you have a big tumor lesion. So we dermatologists are fortunate enough to see the early stages of lymphoma. And the downside of this process is that early biopsies are often non-diagnostic. So do not feel upset or frustrated if you go a few years with an atypical presentation. We don't know for sure. That's very common and is not exceptional whatsoever. I just wanted to clarify that point.
Thank you for that.
Actually, I just want to second this. It's absolutely true. And those diagnoses, even for the best specialist in the world, you know, we do not have a specific marker for CTCL at this time. There's not a magic bullet. There is not a single thing that we can hang our hat on. We really need sometimes to investigate and look, and even in the most difficult cases, we see these rashes and we cannot really firmly establish the diagnosis sometimes because the pathology is not consistent with what we know. And sometimes it takes years for the patient to kind of manifest itself. And it's extremely difficult for the patients, but let me tell you, it's extremely difficult for the doctors too. We are on your side. We are with you. We would like to support you, and we feel your frustration and we feel your pain. And so I hope that, you know, with the Cutaneous Lymphoma Foundation, this wonderful organization that supports the patients and raising money for research in cutaneous lymphoma, we will be able to actually raise enough money to answer this question and many others.
Thank you both so much. You got through an amazing 21 questions today in less than an hour. So I think that might be our best answers yet. So thank you again for joining us, and thank you everyone for attending, and we hope to see you at some future events.
Thank you all.
Thank you so much.